Hi, I'm Bianca Leonardi. I'm a third-year Neonatology fellow at Rainbow Babies and Children's Hospital. Today I'll be talking to you about our quality improvement initiative to decrease rule-out sepsis NICU admissions for infants greater than or equal to 35 weeks gestation by implementation of an early onset sepsis risk calculator. Maternal chorio, which complicates 3 to 4% of all deliveries nationally, is a known risk factor for the development of early onset sepsis, although most of these infants appear well clinically. Despite the low incidence of true culture-positive sepsis of 0.5 to 1.2 per 1,000 live births, several large academic institutions report evaluating and treating up to 15% of all infants that are born greater than 34 weeks gestation. CDC guidelines, along with the coffin statement, call for laboratory evaluation and antibiotic therapy for even well-appearing infants born to mothers with chorio. This leads to costly NICU admissions, disruption of the family unit, painful procedures, and potentially unnecessary antibiotic exposure. And as we all know, antibiotic exposure within infancy is not without risk and has been linked to obesity, asthma, disruption of the intestinal microbiome, and development of multi-drug resistant pathogens. Prior to implementing our protocol, all infants born to mothers with chorio were directly admitted to the NICU for a minimum of 48 hours for evaluation and treatment of possible sepsis, regardless of their clinical appearance. Whether or not to perform a lumbar puncture, along with the duration of treatment, were often based on results of the CBC and CRP that were obtained at 24 hours of life. With this in mind, we developed a smart aim to utilize the publicly accessible Kaiser Early Onset Sepsis Calculator to reduce our NICU admissions from 100% to 60% by January of 2016 for rule-out sepsis in infants greater than or equal to 35 weeks gestation who were born to mothers that were diagnosed with either chorio or fever, all while avoiding any cases of missed sepsis. For anyone who hasn't used the sepsis calculator, the easiest way to access it is by going to Google and typing in neonatal sepsis calculator and following the link. Once there, you simply fill in the boxes and click calculate. It will provide you with a risk of sepsis at birth and following clinical exam, along with clinical recommendations that range from routine observation, obtaining a blood culture, to empiric therapy. They also give clear exam and vital sign findings to classify the infant by, either well, equivocal, or ill. Our drivers of change for this initiative focused on identification of at-risk infants and education of clinicians and families, along with staff training on proper use and interpretation of the sepsis calculator. This annotated run chart displays our initiative's progression from planning to implementation, along with times for re-education. Our primary outcome of monthly NICU admission rates for evaluation and treatment of sepsis is reflected by the blue line, along with our secondary outcome of sepsis rates, which is reflected by the orange line. Following implementation, we had 2 shifts in our median admission rate, which first declined from 100% to 42%, and then from 42% down to 17%, and this is reflected by the purple line. During this time, we had a single case of bacteremia, and that infant was identified as clinically ill at birth and appropriately treated. The remaining cases of sepsis were diagnosed by clinical criteria, which included clinical illness that warranted greater than 48 hours of antibiotic therapy. We had no cases of culture-positive missed sepsis during the immediate newborn period or within 1 week following discharge from the hospital. From June of 2015 to September of 2016, we identified 372 at-risk infants and evaluated them using the sepsis calculator. We prevented 279 admissions during this time. When we looked at indications for NICU admission and treatment at birth, respiratory distress, followed by neonatal encephalopathy, were the most common causes. Among infants who were deemed well initially, some went on to develop an equivocal exam or clinical illness that prompted NICU admission for evaluation and treatment. The most common cause of this was temperature instability, specifically hypothermia. However, we found that no baby who had isolated temperature instability met our criteria for sepsis. This chart represents the number of infants who were initially well and became symptomatic, which is depicted by the purple line, and out of those, few met criteria for sepsis, which is depicted by the red line. And again, none of these were cases of culture-positive sepsis. Implementation of the Kaiser Sepsis Calculator protocol for infants at high risk for neonatal sepsis decreased our NICU admission rates. We saw a diminished financial burden associated with diminished NICU admissions and estimated over $2 million in prevented care for our institution in a year's time. We've decreased our practitioner practice variability, along with decreasing painful procedures by relying on clinical rather than laboratory assessments for these babies. We've promoted family bonding and shown better breastfeeding rates when these babies are able to remain in the newborn nursery with their mothers versus being admitted to the NICU. And last but not least, we've promoted antibiotic stewardship by reserving antibiotic therapy for those infants who are most clinically ill. And I would like to thank our multidisciplinary team for all of their contributions to this project. Thank you for your time.